Testing, testing, mic check, mic check. Testing, testing, mic check, mic check. Okay, give me your,
Look sharp today. Really sharp. Sharp dressed man. We're talking about other potential ones. Bill Roush. When he's going to run for office. Bill's too much of a personality. And everybody loves him. And always smiling. So it's like he and grumpy, you know.
I have a face for radio. Okay. I have a face for radio and I'm a face for media.
Right, yeah, you know that.
When I was a kid,
check, 1, 2, 3.
The subcommittee will come to order. And before we begin, I'd like to ask unanimous consent for our colleagues and fellow committee members, Representative Zeldin from New York, Representative Boss from Illinois, Representative Custer from New Hampshire, and Representative Walorski from Indiana to sit on the dais and participate in today's proceedings. So without objection, so ordered. Good morning, and thank you all for joining us for today's legislative hearing. Our agenda this morning includes 6 bills. The bills are H.R. 2460 to improve the provision of adult day health care services for veterans, H.R. 3956, the VA Health Center Management Stability and Improvement Act, H.R. 3974, the Grow Our Own Directive, Physician Assistant Employment and Education Act of 2015, H.R. 3989, the Support Our Military Caregivers Act, and draft legislation to ensure that each VA medical facility complies with the requirements relating to scheduling veterans for healthcare appointments and to improve the uniform application of directives, and draft legislation to direct the VA to establish a list of drugs that require an increased level of informed consent. These pieces of legislation cover a wide range of topics facing our veterans and their families. One bill on our agenda that I look forward to discussing is H.R. 3956, the VA Health Center Management Stability and Improvement Act. This bill, which is sponsored by Representative Boss, would require the VA to develop and implement a plan to hire directors at VA medical facilities, prioritizing those that have been without permanent leaders for the longest time. The number of VA medical facilities that have gone without stable, consistent, long-term leadership is alarming. We have to encourage the VA to take every possible action to bring high-quality leaders to the helm. Another bill that I look forward to discussing is H.R. 2460, a bill sponsored by Lee Zeldin that would authorize the VA to cover costs for adult day health care at state veterans' homes for certain veterans. It is critical that we increase long-term care options for our veterans, particularly those who can and want to live at home for as long as possible, but need additional assistance during the day. I'm also eager to discuss H.R. 3989, a bill sponsored by Representative Stefanik to address the growing application backlog in the Family Caregiver Program, and draft legislation sponsored by Representative Walorski to ensure that VA medical facilities comply with scheduling directives. I'm grateful to all my colleagues for introducing the bills on our agenda this morning and thank them for being here today to discuss them with us. I am also grateful to the representatives from our veteran service organizations and from the Department of Veteran Affairs for being here this morning as well. And I'll now yield to the ranking member, Ms. Brownlee, for any opening statement that she may have.
Thank you, Mr. Chairman, and thank you for holding this hearing today. Among the many bills being considered today is my draft legislation on increased informed consent. Over the past few years, the Committee on Veteran Affairs has heard testimony from veterans using opioids for long-term pain management and the severe side effects that are often associated with that treatment. Time and time again, we have heard from veterans who were not fully aware of the potential side effects of these medications or that alternative treatments to prescription medications were indeed available. My draft legislation is designed to open up a meaningful dialogue between the veteran and the physician by raising the standard for informed consent for certain drugs prescribed by doctors at the Department of Veteran Affairs. It would also require the Veteran Health Administration to form a clinician panel that would establish and maintain a list of drugs which may only be furnished to a patient with increased informed consent. In the past few years, the VA has worked to address the prescription drug crisis. While I appreciate the Department's work to prevent prescription drug abuse and overdoses, I still feel their efforts have not gone far enough. The goal for the draft legislation is to encourage a real conversation between the veteran and doctor at the point when a treatment plan is presented to the veteran, and a conversation that goes beyond the VA's existing standardized form, which was last updated in 2014. Under the discussion draft, if a drug identified by the clinician panel is prescribed by a VA doctor, that provider would prepare and present a written improved consent form to the patient. For drugs with improved informed consent, the veteran's doctor would provide written information and discuss with the veteran the risk of dependency, known interactions between the drug and other drugs or substances, including alcohol, if the drug has an FDA black box warning, and if any alternative treatments are available and might be helpful. This form would not require the patient to commit to that treatment plan. It would also give the patient the opportunity to review the information provided regarding the recommended treatment and any other possible treatments. Additionally, the patient would have the opportunity to speak to a VA pharmacist if the patient has additional questions about the drug being described. I recognize that veterans, their families, or indeed some members of this committee, like me, are not experts in medical care. The intent of this legislation is to not tell doctors how to treat their patients, but to ensure that veterans are confident they have the information they need to make an informed decision about what would be best for their long-term health. Before they pick up that first prescription, the veteran deserves to have all of their options laid out. Since the discussion draft was released, I have received support on the principles behind the draft from many veteran groups and constructive comments from healthcare providers regarding the scope of the language. I look forward to working with all interested parties to improve on the proposal and bring some level of control and decision back to the veteran when the treatment of his or her injury or illness is being addressed. I thank the VA for their testimony this morning, as well as their willingness to meet with my staff to address the concerns raised in the draft language. We can all agree that including the veteran in the decision-making process in a meaningful way is the right way to go when it comes to the veteran's health care. This language is my attempt to bring that about. Thank you for this opportunity, Mr. Chairman, and I yield back the balance of my time.
Thank you, Ms. Brownlee. Well, I'm honored to be joined this morning by several of my colleagues to speak in support of their legislation. I think Mr. Zeldin will be joining us. We do have the Honorable Mike Boss from Illinois, the Honorable Ann Custer from New Hampshire, the Honorable Elise Stefanik from New York, and the Honorable Jackie Walorski from Indiana. Thank you all for being here today. I'm going to yield first to Representative Stefanik and then Mr. Boss. As I understand, they both have markups to attend other committees this morning. So, Representative Stefanik, please proceed with your testimony.
Chairman Benishek, Ranking Member Brownlee, thank you for the invitation to testify on this important legislation. I truly appreciate the opportunity to appear before you and look forward to discussing this key issue. As a member of the House Armed Services Committee with a critical Army base and Navy nuclear training facility located in my district, I am dedicated to providing support to service members, veterans, and their families. Since September 11, 2001, the Army's 10th Mountain Division at Fort Drum has been the most actively forward-deployed division in the global war on terror. Over the last 15 years of war, our service members have bravely served our nation, and their families have sacrificed an immeasurable amount. So it is vital that we ensure they receive the best possible care. This is especially true for our military caregivers, loved ones of our service members who selflessly care for our heroes behind the scenes. These men and women are often left out when discussing veterans issues. Military caregivers are an essential component of the communal and family support system for our disabled veterans. They are usually spouses and other family members who spend their days transporting and caring for disabled veterans in order to provide an environment that enhances their everyday lives. In 2010, Congress passed a law implementing the Family Caregiver Program. This was an important piece of legislation that made veterans who sustained injuries in the line of duty eligible for a package of benefits that includes access to a primary caregiver. These benefits would ensure that the family members who dedicate their lives as caregivers receives access to health care, caregiver training, and stipends for additional costs associated with their disabled veteran. Unfortunately, the Department of Veterans Affairs has had a difficult time managing the high demand of family caregiver enrollees, which is much larger than originally accounted for during implementation. According to the Government Accountability Office, VA officials estimated they would receive 4,000 enrollees and staff the program based on this estimate. However, in the first few months of implementation, there were over 15,000 enrollees to the Family Caregiver Program. VA medical centers lack sufficient caregiver support coordinators and the necessary clinical staff to carry out medical assessments for eligibility for this program. These implementation issues have led to a delay in both the application and the appeals process. Application deadlines are not being met by their own internal standards, and the staff is still short-handed. These issues are not only unacceptable, but I believe they are preventable. And after meeting with a constituent who is a caregiver facing the burden of the VA backlog, I introduced H.R. 3989, the Support Our Military Caregivers Act. This bill would use pre-existing funds already appropriated for the current review and appeals process to then allow for an objective, independent party to conduct external clinical reviews. This bill would ensure that new or modified processes are veteran-centric, outcomes-based, and continually improved through the use of best practices. We can accomplish this by permitting a third party to work within the VA to streamline claims and reduce the caregiver backlog through a more clinical analysis rather than benefits adjudication. The VA would maintain this third party until appeals are streamlined and the backlog is down to an acceptable rate and addresses the issues highlighted by the GAO. Military caregivers are truly the silent heroes in our communities and deserve the respect and benefits proportionate to their significant contributions. I would also like to highlight that this legislation is supported both by the Elizabeth Dole Foundation and American veterans. I look forward to discussing this issue further in order to implement a solution and get our military caregivers the benefits they deserve. Thank you.
Oh, thank you very much, Ms. Stefanik. Mr. Bost, you're now recognized.
Thank you, Mr. Chairman. Chairman Benishek and Ranking Member Brownlee, thank you for allowing me to testify on this bill today. We must be very, very careful in considering, when we're consideration of how to reform the Department of Veterans Affairs and ensure access to quality health care our veterans deserve. As a Marine and the father of a Marine, I recognize the sacrifices that so many Americans have made in defense of our freedom. There's no doubt that we must fight for the brave men and women who have fought for us. I know my colleagues on both sides of the aisles feel the same way. But we need steady leadership and long-term vision. No organization can operate under a revolving door of intern leadership, and certainly not one that's given the task of caring for our American heroes. Yet, this revolving door is occurring at VA medical centers across this country. This undermines the quality and speed of the care that our veterans receive. That's unacceptable. That's why I introduced House Resolution 3956, the VA Health Center Management Stability and Improvement Act. The bipartisan legislation requires the VA Secretary to create a plan for hiring a permanent and qualified director at every VA medical center. My bill is endorsed by the American Legion, Vietnam Veterans of America, Paralyzed Veterans of America, AMVETS, Disabled American Veterans, and the Association of the United States Navy. The issue first came to my attention in my own backyard. Many Southern Illinois veterans receive treatment from the St. Louis VA Medical Center. The St. Louis VAMC provides health care for 45,000 veterans annually, all under the cloud of temporary leadership. I remain very concerned about the lack of stability and how it impacts system operations. Over the last several years, the St. Louis VA has been managed by more than 7 different acting directors. After I began looking into the local issue at the St. Louis VA Medical Center, it came to my attention that this isn't a problem that just exists in that area. Upon further investigation, I found dozens of VA medical centers that have lacked a permanent director for quite some time. The problem is due to the OPM requirements, which stipulate that the temporary directors can serve no more than 120 days, with a 240-day maximum total in their tenure if their tenure is extended. The lack of stability and permanent leadership is no doubt one of the reasons the Department of Veterans Affairs has been struggling to provide appropriate health care to those it serves. House Resolution 3956 seeks to fix the problem and fix it now. Specifically, it requires the VA Secretary to, 1, report the status of any unfilled vacancy to the House and Senate Veterans Affairs Committee. 2, identify possible issues leading to the lack of staffing for these unfilled permanent directors' vacancies. 3, assess the possibility of promoting and training qualified candidates from within the VA for promotion to these leadership positions. 4, develop a plan to hire highly qualified medical directors for each VA medical center which lacks a permanent director. And 5, submit this plan to Congress within 120 days of enactment of the bill. I've reached out to my local congressional colleagues and sent letters to the department regarding the lack of leadership at the St. Louis VA-MC. Last week, I received a reply from the VA Undersecretary of Health giving me an update on the issue. According to his timeline, the St. Louis position has been vacant since July 14, 2013. That's 33 months. I have enclosed a copy of the St. Louis VA Medical Center Director timeline with the formal statement to illustrate just how long this gap has been. This problem doesn't end in St. Louis. Unfortunately, similar scenarios can be found in the Department of Veterans Affairs medical centers across the country. According to the VA Health Undersecretary Shulkin yesterday, in his testimony before this committee, there are currently 34 VA-MCs without permanent directors. House Resolution 3956 would help improve the leadership at the VA medical centers and so many of our nation's veterans rely on. I thank the subcommittee for considering House Resolution 3956, and I look forward to working with you in a bipartisan way to advance this legislation, and thank you, and I yield back.
Thank you very much, Mr. Boss. Ms. Custer.
Thank you, Mr. Chair. Thank you very much, Chairman Beneček and and Ranking Member Brownlee and the members of the subcommittee for the opportunity to discuss H.R. 3974, the Grow Our Own Directive, Physician Assistants Employment and Education Act of 2015. Our full committee has worked hard to improve veteran access to health care and to create opportunities for veteran education and employment. This legislation will allow us to merge those efforts and allow veterans to continue serving their country while in service to their fellow veterans. In the 14 and a half years since September 11th and the 13 years since the invasion of Iraq, the men and women of the United States military have repeatedly demonstrated their skill, valor, and professionalism. They have repeatedly placed their lives on the line, been separated from their families, and deferred their own personal life goals in order to serve our country. As many in this room recognize, that service on our behalf creates an obligation on our part to ensure that our veterans have the opportunity to succeed and have access to the medical care they may require. Veterans today often leave the service with an incredible skill set. Our corpsmen and medics have proven medical experience in high-pressure training and real-world environments. They have also demonstrated an interest in public service by volunteering to serve in the military, and many hope to continue in service to the public after they leave active duty. Meanwhile, as this subcommittee in particular knows well, veterans often face challenges in accessing care. As we discussed last week, sometimes this is due to IT and scheduling changes, but at other times it's due to a lack of medical providers available. In a time of shortage for primary care providers, both in the private sector and in the VA, with the Office of Inspector General listing physician's assistants as one of the VA's top 5 occupations with the largest staffing shortages, creating a pathway of opportunity for our veterans to fill that gap and continue to serve their country seems to me to be like an excellent opportunity. H.R. 3974 would accomplish that objective by creating a pilot program to provide educational assistance to qualifying veterans for education and training as VA physician assistants. A veteran would qualify for this program who has medical or military health experience gained while serving in the armed forces, has received a certificate, associate's degree, baccalaureate degree, master's degree, or post-baccalaureate training in a science related to healthcare, has participated in the delivery of healthcare services or related medical services, and does not have a doctorate in medicine, osteopathy, or dentistry. Eligible veterans would be able to apply during the 5-year pilot program to receive one of 35 scholarships available each year to cover the cost of obtaining a master's degree in physician assistant studies or a similar master's degree. Selection would be prioritized for those veterans that participated in an earlier veteran recruitment program known as the Intermediate Care Technician Pilot Program, and those veterans agreeing to be employed by the VHA in a community that is medically underserved and in a state with a significant veteran population. Those veterans that use the program would then owe the VHA a period of obligated service based either on the scholarship program used or 3 years. To ensure that veterans are prepared to succeed, participants will be paired with a mentor at their facility, and the VA will partner with institutions of higher learning to guarantee physician assistant educational seats. As it is currently written, the bill would also establish standards to improve the education and hiring of VA physician assistants and enhance retention and recruitment through competitive pay standards. As this bill moves through the House and the Senate, there have already been several discussions to find ways to improve the bill, to increase its chances of passage, and to create this opportunity for our veterans. I'm happy to continue those conversations in the coming weeks and days, and based on feedback from this hearing and from my colleagues. Mr. Chairman, this concludes my statement, and I'd be happy to answer any questions. Thank you.
Thank you very much, Ms. Custer. Ms. Walorski? You're now recognized.
Thank you, Mr. Chairman. Good morning. And good morning, Ranking Member Brownlee and my fellow colleagues. I appreciate the opportunity to discuss House Resolution 4977, the VA Scheduling Accountability Act. In 2014, news reports uncovering gross mismanagement and schedule manipulation at a Department of Veteran Affairs hospital in Phoenix shook us all to the core. Through hearings held in this committee and investigations by the VA, OIG, and GAO, we together substantiated many of the allegations of manipulated schedules and falsified wait times data at the Phoenix facility. The manipulation of appointment schedules and data in Phoenix led to at least 40 veterans dying while they were waiting for care. However, as we all took a closer look, we discovered that, sadly, this was not an issue unique to Phoenix. It was systemic. Here we sit 2 years later, digging deeper into some of the root causes to ensure that no veteran ever dies again waiting for care. So I introduced legislation this week, the VA Scheduling Accountability Act, that gets at one of the key drivers of the wait time manipulation. A 2010 VA directive and VA's implementation processes and procedures policy for scheduling at their facilities, and contains 19 different items on the checklist. The directive requires an annual certification of full compliance with all items on the list. For instance, facilities are required to ensure completion using VISN-approved processes and procedures of a standardized yearly scheduler audit of the timeliness and appropriateness of scheduling actions and of the accuracy of desired dates. They're also required to ensure that deficiencies in competency or performance are identified by the annual schedule or audit are effectively addressed. An August 2014 OIG report uncovered that in May of 2013, the then Deputy Undersecretary for Health for Operations Management waived that FY 2013 annual requirement for facility directors to certify compliance with the VHA scheduling directive, allowing facilities to only self-certify reduced oversight, overweight time, data integrity, and compliance with appropriate scheduling practices. This, in turn, allowed VA's data to be easily manipulated, contributing to the wait time scandal. There was a noticeable, substantial improvement in VHA's appointment scheduling after VA waived the directive, but as we all know now, that improvement was an illusion. While the VA has reinstated the certification requirement, there's nothing stopping them from waiving it again. The VA Scheduling Accountability Act would simply require each facility director to annually certify compliance with the scheduling directive or any successor directive that replaces it, and it prohibits any waivers in the future. Should a director be unable to certify compliance, either because the facility is not in compliance or the director refuses to sign the certification for some other reason, the director must submit a report directly to the secretary explaining why the facility is out of compliance. The secretary will then have to report yearly to the House and Senate VA committees with a list of facilities in compliance and those that are not, with an accompanying explanation as to why they were not in compliance. This will provide more oversight of the department and ensure Congress is aware when VA is waiving these policies. Waiving compliance requirements was a key driver in the wait time scandal, which continues to be an issue with the department. This legislation will begin to end that reckless practice once and for all, while increasing accountability and transparency at the VA as we work on ways and continue to work on ways to ensure that those who risk their lives for their country receive the prompt, quality care that they've earned. I look forward to working with the members of this committee, veteran service organizations, and the VA in addressing this critical issue. And I again thank you for allowing me the opportunity to speak today, and I yield back.
Thanks, Ms. Wolarski. Mr. Zeldin, you're recognized.
Good morning, Chairman, and thank you for the opportunity to testify on behalf of my bill, H.R. 2460, which provides no-cost medical model adult day health care services for our 70% or more service-connected disabled veterans. It must always be a top priority of Congress to ensure that all veterans receive the proper treatment and care they deserve after fighting for our country. While overseas, these brave men and women are exposed to hardships and trauma, and when they come home, many return with the physical and mental wounds of war. Despite various care options for veterans, their choices are often limited and can come at a great expense. Service members who are 70% or more disabled from a service-connected injury often require significant assistance from others in order to carry out basic everyday tasks. In many instances, veterans must rely on family members for assistance, creating many financial and emotional hardships. Alternatively, some veterans without the proper support system may even be forced to rely on the assistance of trained medical professionals and reside in institutionalized facilities for daily assistance. Veterans in these facilities often spend significant sums of money each day just to be enrolled, and these expenses can be expected to span the remainder of the veteran's life in many cases. While alternative options currently exist, accessing these services, however, can often be very difficult. One such program that is currently available is Adult Day Health Care, a daily program for disabled veterans who need extra assistance and special attention in their day-to-day lives. Adult Day Health Care programs provide disabled veterans and their families with a high-quality alternative to nursing care, providing quality outpatient services for those suffering from debilitating illnesses or disabilities. These programs provide a range of services from daily activities such as bathing to full medical services like physical therapy. Adult Day Health Care is only offered currently at 3 facilities in the United States. Long Island, where I represent, is fortunate to be the home of one of these 3 locations, which offer adult day health care, the Long Island State Veterans Home in Stony Brook, New York. But this program could easily be offered at any of the 153 state veterans homes across the country. However, the Department of Veterans Affairs does not currently cover the cost of participation in this program at state veteran homes, and the expense of the program is put directly on the veteran and their family, which significantly limits the number of veterans who can enroll. In an effort to address this and expand access to care for our heroes, I introduced bipartisan legislation, H.R. 2460, which would ensure that 70% or more service-connected disabled veterans are able to receive adult day health care at no cost to the veteran and their family by defining the program as a reimbursable treatment option through the VA. My bill would guarantee that all severely disabled veterans are able to access adult day health care. By providing disabled veterans with access to adult day health care programs, we can ensure that all veterans receive the best and most efficient outpatient services to provide them with the assistance and special attention that they need in their day-to-day lives, while still allowing them to maintain their independence. Adult day health care also helps keep families together and strong. With the inclusion of adult day health care services as a covered VA expense, family members and caregivers can rest easier knowing that their loved ones are receiving top-notch care during the day while being treated with the same respect and dignity that they would receive at home. Not only does the adult day health care model care for the medical needs of a veteran, but it also addresses their social and emotional needs as well. Adult day health care allows veterans to interact and socialize with their peers and other individuals enrolled in the program. Rather than sitting home alone all day, participants in the adult day health care program receive one-on-one attention from medical and support staff, while also maintaining an active social schedule through planned events and activities. Family members and caregivers can go about their day without the worry that their loved ones are unattended, and the veteran can continue to remain as active members of their community. It should be noted that treatment at adult day health care is $40 to $50 less on average than nursing care would cost. It is a top priority of mine to ensure that all veterans on Long Island and across the country receive the proper treatment and care they deserve, which is why I fully support the adult day health care program. Thank you, Chairman, and I yield back the balance of my time.
Thank you, Mr. Zeldin. Do any of the members here have questions for these members that have proposed legislation before us? Dr. Rowe.
I do. I think one of the, on Ms. Brownlee's legislation, at least from a practice and physician standpoint, it makes it extremely difficult as it is. I'd like to work with you on that, but this is virtually impossible to do as it's currently written. And there's not enough time in a day to go through all the possibilities that you've laid out. And I pulled up Tetoxine, which is Prozac, and just went through the list of side effects of that drug. It would take you a day to go through all that the way it's listed. And I think certainly the intent is to inform people about the possibility of addiction in opioids. That everybody at this dais agrees on. The question is just how to do it. And I know as I read this, I thought, I don't see how I could do this the way it's currently written and see patients the rest of the day. I don't know how I'd like to hear some of the other colleagues step up, and Dr. Ruiz or others, and I'll yield to Ms. Brown.
Thank you, Dr. Rowe, and I appreciate the comments and would like very much to work with you. I think, part of the bill says we're going to set up a panel of clinicians to decide those, in my layman terms, most dangerous drugs to have this interaction with. So it wouldn't be, Prozac probably wouldn't be on the list. It would just be those opioids and other kinds of, high-level drugs that we see as sometimes can have the wrong effect. So I think, this is draft legislation right now. That means it still needs to be worked on, but I wanted to introduce it to the committee to get people's feedback so that we can get to a bill that everyone can support. So I appreciate the feedback.
I'd like to work on it. And just to give you an example here, one particular drug, if you have stiff muscles, high fever, sweating, fast or uneven heartbeats, tremors, overreactive reflexes, nausea, vomiting, diarrhea, loss of appetite, feeling unsteady, loss of coordination, headache, trouble concentrating, memory problems, weakness, confusion, hallucinations, fainting, seizures, shallow breathing that stops, I would certainly think that would be a problem. Skin reactions, fever, sore throat, swelling on your face or tongue, burning on your skin. I could go on for another 15 minutes. So this is why I think we have to back up and really narrow this down so that people understand, look, if I'm progressively increasing more and more narcotic, I have a high risk. I mean, that's something fairly reasonable, and I would love to work with you. I know the intent, but it's the application of this could be very, very difficult, I think.
Very good. Thank you.
Are there any other questions? Well, I guess most of the people on that panel are gone. Ms. Custer, thank you for participating this morning. Appreciate you being here. So the first panel is excused, and I'll welcome our second panel to the witness table. Joining us on the second panel is Diane Zumato, the National Legislative Director from AMVETS, Sharonda Love, the Assistant National Legislative Director for the Disabled American Veterans, and Fred Skanga, the Legislative Officer for the National Association of State Veterans Homes. I'd like to thank you all for being here and for your hard work and advocacy on behalf of our veterans. So I look forward to hearing the views of your members. And Ms. Zumato, you may begin when you're ready.
Thank you, Mr. Chairman. I'm happy to be here today on behalf of AMVETS. Before I begin my specific remarks, I just want to ask that this committee remembers that the health care obligations imposed by the sacrifices of our veterans are met in a timely, professional, and compassionate manner. I would also urge you to reject any plan to eliminate the VA from hands-on care of our veterans. As far as H.R. 2460, AMVETS supports this legislation, which seems like the best of both worlds in that it provides the appropriate and necessary care for veterans in a more cost-effective manner, while also providing an improved quality of life. The legislation directs the Secretary of the VA to enter into an agreement or contract with each state home to pay for adult day health care for a veteran eligible for but not receiving nursing home care. H.R. 3956, AMVETS supports this legislation, which seems to be a bit of a no-brainer to us. Medical centers without directors will most likely not perform as well or as consistently as those that do. H.R. 3974, AMVETS supports the legislation which builds upon and leverages the training and experience of former military members. This bill directs the VA to carry out the Grow Our Own Directive pilot program to provide educational assistance to certain former members of the Armed Forces for education and training as VA PAs. 3989, AMVETS is very supportive of this bill, which permits an individual to elect to have an independent contractor perform an external clinical review related to their caregiver or their caregiver benefits. This is important because things change over time. The needs of both the veteran and the caregiver are likely to change, including but not limited to the amount of care the veteran requires, could increase or decrease. The amount of time the caregiver has available to assist that veteran could increase or decrease. The caregiver might prove to be unable to perform the necessary duties. The caregiver also might prove to be unethical or irresponsible, and their level of expertise will change. So we just feel that this would provide a much-needed way out of a possibly unsuitable situation. The draft legislation to ensure that VA medical facilities comply with requirements related to appointment scheduling and to improve the uniform application of directives. AMVETS feels strongly that there needs to be continuity across the VA healthcare system, and this bill should help to make that recommendation a reality. Finally, draft legislation on informed consent. This is a top issue for AMVETS, and we wholeheartedly support this legislation because we believe that the health and welfare of our veterans needs to come first. This means that their interests come before any VA employees, including physicians. AMVETS believes that having the veterans' buy-in and clear understanding of any proposed risky medications will not only provide much-needed peace of mind for the veteran and their family, but will be instrumental in the overall healing process. An informed patient is much more likely to fully comply with their doctor's instructions and much less likely to complain or be dissatisfied with their treatment. Let me be clear that our intention in supporting this legislation is not to burden or disrespect VA doctors, but to provide veterans the opportunity to be more actively involved in their health care treatments. In order to minimize the burden on physicians, AMVETS suggests utilizing nationally standardized medical educational materials, which could be adopted by the VA and made available either digitally or in a pre-printed format, such as a medication guide. All of the medications which would require informed consent would either be available in a database whereby each medication with its additional information could be printed for each specific covered medication and provided to the patient. If utilizing the pre-printed medication guide, each covered medication would be included with all of the same additional information as the database option, which is in the written testimony, so I'm not repeating that. The physician would then merely have to check off the recommended medications and hand that information to the patient. In both cases, a consent form would be provided to the patient for his or her signature in either an electronic or paper format. The patient's signature at this point merely indicates that they have been provided with the information regarding any covered medications and should not yet be understood as an acceptance of the proposed treatment plan. At this point, the patient should be given the opportunity to ask any immediate questions of the physician, or the veteran could be referred to a pharmacist for further information. The patient then would be given 3 full business days from the issuance of the initial recommended prescription to either consider and internalize the information provided by the doctor, conduct any additional research, seek a second opinion, discuss with family, or get a legal opinion. At the end of the 3-day period, the patient would then convey their approval or disapproval of the suggested medication or medications via secure messaging, phone, email, or fax directly to the prescribing physician or his or her office. The veteran's signature, along with the follow-up, whether it's oral or written, at the end of the 3 days, would jointly fulfill the informed consent signature requirement, so there would be no further reason for the veteran to return to the doctor's office on this matter unless there were extenuating circumstances. It appears that I have gone over time, so I'm going to leave it at that, and I'd be happy to answer any questions. Thank you.
Thank you very much. Ms. Love, you're recognized.
Mr. Chairman and members of the subcommittee, thank you for inviting DAV, Disabled American Veterans, to testify at this legislative hearing. As you know, DAV is a nonprofit veteran service organization comprised of 1.3 million service-disabled wartime veterans. I will provide comment on 3 of the bills before the subcommittee. My written statement covers all bills and drafts relative to this hearing. DAV is pleased to support the intent of the discussion draft for increased informed consent. However, we recommend VA include pharmacy personnel on all PAC teams to lessen the burden on physicians. H.R. 2460, if enacted, would authorize the Secretary to enter into agreements with state veteran homes to provide adult day health care for veterans who are eligible for but not receiving skilled nursing home care. Eligible veterans are those who require such care due to service-connected disabilities or who have a disability rating of 70% or more disabling and are in need of such care. The payment to the state home under this program would be at the rate of 65% of the amount that would be payable to the state home if the veteran were an inpatient receiving nursing care. Payment by the VA would then be considered payment in full. The Adult Day Health Care is a program for veterans who need assistance with activities of daily living, nursing services, and case management. It is also beneficial for those veterans with caregivers who may be experiencing isolation from their own lives and are in need of respite from the constant care of their loved ones. During the time spent at the Adult Day Health Care program, veterans receive the health care services they need in addition to peer support, companionship, recreation, and social activities. The healthcare services received would be based on their personal needs and could range from a full or half day 2 to 3 times per week. Veterans want to be independent for as long as they can without being burdensome to their families. In addition, they still want to remain an active part of the family unit. Adult day health care helps to accomplish this goal by allowing the caregiver respite to take care of their personal needs while the veteran has an opportunity to interact with their peers while obtaining the health services that they need. DAV is pleased to support H.R. 2460, which is in line with DAV Resolution Number 101, adopted at our most recent national convention, calling for the support of state veterans' home programs, recognizing state home care as the most cost-effective care available for sick and disabled veterans with long-term health care needs outside of the VA healthcare system. H.R. 3989, if enacted, would establish an external review process in cases in which the VA has denied caregiver benefits, approved a level of benefits considered inadequate to the needs, or revoked benefits. A decision on this review, once requested by the caregiver, would be required by the bill to be completed within 120 days. DAV has continued to express the need for an independent mechanism through which a caregiver can appeal the clinical team's decision. That decision can be reviewed de novo, and an unwarranted decision can be reversed, altered, or sent back to the clinical team with instructions to reassess or consider additional factors. H.R. 3989 offers a review of a VA decision. However, it is unclear if the review would be binding on VA or whether the recommendations from the contractor would be cause for VA to issue a new decision based on the review findings. For caregivers who feel they are unduly denied benefits, VA must establish a systematic recourse and provide a publicly accessible program handbook or directive outlining mandatory program policies, procedures, and operational requirements, which would serve to inform and educate those enrolled and seeking enrollment into the program. DAV is pleased to support H.R. 3989 as it is in line with DAV Resolution Number 106, calling for legislation to provide comprehensive support and services to caregivers of all veterans severely injured, ill from military service. DAV has no objection to the passage of the remainder of the bills before the subcommittee. Mr. Chairman, DAV appreciates the opportunity to provide testimony. I will be pleased to address any questions you or the subcommittee members may have on these bills.
Thank you, Ms. Love. Mr. Skanga, you're recognized.
Mr. Chairman and members of the subcommittee, thank you for this opportunity to testify in support of H.R. 2460, introduced by Congressman Lee Zeldin of New York to provide severely disabled veterans with an enhanced option to receive adult day health care services from a state veteran's home. I'm Fred Skanga, the legislative officer and past president of the National Association of State Veterans Homes. I also have the high honor of serving as the executive director of the Long Island State Veterans Home at Stony Brook University, a 350-bed state veterans home that also operates a 40-slot medical model adult day health care program. Mr. Chairman, a decade ago, Congress passed legislation to assist our most disabled veterans by allowing them to receive skilled nursing care in state veterans home under a new program where VA paid the full cost of care to the state veterans home with no cost charged to the veteran. Unfortunately, the law did not cover alternatives to traditional institutional care, such as medical model adult day health care, which is currently being provided at 3 state veterans homes in Stony Brook, New York, Minneapolis, Minnesota, and Hilo, Hawaii. H.R. 2460 would fix that. Adult day health care is designed to promote wellness, health maintenance, socialization, stimulation, and maximize the participants' independence while enhancing their quality of life. A medical model adult day health care program also provides comprehensive medical, nursing, and personal care services. As a licensed nursing home administrator, I would like to thank Congressman Zeldin for recognizing the need to offer non-institutional alternatives to our veterans. The legislation would also be especially important to veterans like Jim Saladino and his wife, Noreen. 50 years ago, Jim answered the call of his country and served in the United States Army during the Vietnam War. Today, Jim suffers from the ravages of Agent Orange exposure, including diabetes and Parkinson's disease. He also recently suffered a stroke.
The Saladino family could have easily decided to put Jim into my nursing home because he is a 100% service-connected veteran, and his nursing home care would have been fully paid for by the VA. But this is not their choice. They would like their loved one to continue enjoying the comforts of his own home for as long as he can, and our medical model adult day health care program does just that. 3 days a week, we pick up Jim and bring him to our home. Working closely with his personal physician, we provide services to help maintain his wellness and keep him out of the emergency room and even avoid unnecessary hospitalizations. During his 6-hour day with us, Jim receives a nutritious breakfast and lunch. He receives comprehensive nursing care. He also receives physical therapy, occupational therapy, and speech therapy. He can get his eyes checked by an optometrist, his teeth cleaned and examined by our dentist, his hearing checked by our audiologist. If required, and his physician orders it, we can get him a blood test or even an x-ray. We can have his vital signs monitored, and we can even bathe and groom him while he's on site. For Jim's wife, Noreen, his primary caregiver, this program gives her peace of mind knowing that he is in a safe and comfortable environment and allowing her to get a break. However, because of the way the law is currently structured, despite Jim's eligibility for no-cost skilled nursing care, the Saladinos are required to pay out-of-pocket for a portion of Jim's adult day health care. Mr. Chairman, H.R. 2460 will fix this disparity by authorizing the VA to enter into agreements with state veterans' homes to provide adult day health care for veterans who are eligible for but do not receive skilled nursing home care under the current full cost of care program. The payment to the state veterans home under this program would be at a rate of 65% of the full amount paid for skilled nursing care, the full cost of care program. This will save the VA money while keeping veterans like Jim Saladino in their own home. For the Saladino family, receiving no-cost medical model adult daycare would relieve a huge financial burden they currently incur. Even though Jim's service ended 50 years ago, he's still paying the price for his valor related to his service in Vietnam. Passing H.R. 2460 would send a strong message to all those who have worn the uniform to protect our freedoms that they will never be forgotten. H.R. 2460 has bipartisan support in the House and has also been supported by the DAV, VFW, American Legion, and vets. I would also ask that the Legion's letter of support be made part of the record. On behalf of the National Association of State Veterans Homes, I urge you to approve H.R. 2460 for Jim and Noreen Saladino and for thousands of others across the country just like them. Mr. Chairman, that concludes my testimony, and I would be happy to answer any questions you or members of the subcommittee may have, and thank you again for this opportunity.
Thank you, Mr. Skanga. I'm going to yield myself 5 minutes for questioning. And I just have a couple questions, and it relates to this, the bill of Mr. Zeldin's. Mr. Skanga, the VA is going to testify because of the level of services for adult daycare and nursing home care are different, and the period of time in which services are furnished are different. They believe that the payment rate proposed for 2460 was inappropriate. So would you please respond to that assertion and explain what, if any, the monetary benefit is available to veterans or to state veterans homes through the VA for adult day health care, and why the provisions and the rate in H.R. 2460 are appropriate and necessary, in your opinion?
Well, in my opinion, back in 2006, when Congress had said any veteran who is 70% or more service-connected disabled is entitled to skilled nursing care, it didn't include adult day health care. Currently, in my home, I'm being paid $489 a day to care for that veteran who falls into that category. At 65% of that rate, I would be paid about $318 a day. That includes, Chairman Benešík, transportation to and from the home. Clearly, $318 a day is less than $489 a day, and it would allow the veteran to live in the comfort of his or her own home. I think what we used as a model was recognized by CMS. In the state of New York, if you receive nursing home care, the state of New York will reimburse that same nursing home who provides adult day health care at a rate of about 65%. So that 65% number is a highly recognized number within CMS.
So, I mean, the services that you described in your testimony, you know, I mean, would the veteran gets a bed then, and for the day, and then he may get his his bath, a lot of the.
That's a great
care?
question. Let me give you an example. We had an 85-year-old Marine who was going to be admitted into the home. His wife could feed him. She could put his clothes on. She could even assist him with toileting. But what puts people in nursing homes, it's their ability to deal with their activities of daily living. For this spouse, she couldn't bathe this gentleman, and for that reason, he qualified for the nursing home. We provided her with the alternative of adult day health care, and now he comes to the program 3 days a week. And now when he comes to the program, we bathe him in the program, put him in a clean set of clothes, and send him home at the end of the day. This couple got to enjoy their 65th wedding anniversary in their own home, living together. So it's those kind of stories that we want to help our vets with.
Let me get this straight now. So these are veterans that are actually eligible for nursing home care.
Yes, and the VA
paid
pays for it.
Over the VA.
Yep.
So this would keep somebody out of the nursing home.
Correct.
And
At lesser
actually
cost.
cost the VA less.
That is
Otherwise,
correct.
they would apply to go to a nursing home, right?
That is correct.
All right. Well, that makes a lot of sense then. Ms. Brownlee, do you have any questions?
Yes, just briefly. And first, I wanted to thank Ms. Samato for helping and working with our staff in terms of drafting the legislation in my draft bill. So thank you very much for that. I think I just wanted to ask, all three of you, really, I think the goal of this bill is to really kind of reach a level of excellence in terms of, the appropriate communication between the doctor and the patient, particularly when a drug may be prescribed that could have serious side effects like addiction and other kinds of things, because that's what we've heard so much about in this committee. So I guess, if you could all comment in terms of, feedback from your veterans on how well the current system is working, and, why you believe, if that this bill, taking it to a kind of another level, to a level, in my opinion, of excellence, is important. Ms. Amato?
Thank you for the question, Ms. Brownlee. There are so many veterans that their quality of life has been compromised because of some of these medications. And many times, since most of us are not doctors, if a doctor tells us, you need to take this or you need to do this, we often don't question them because we don't feel qualified. And so we just tend to do whatever the doctor says, which may be the appropriate thing to do. But what we would like to do is ensure that the veteran understands any of the risks that are going to be involved, or if there may be perhaps a less invasive procedure, medication that could be tried before perhaps moving to this more dangerous medication. And, to your question, Dr. Rower, your comment about not having the time as a physician, we do appreciate the short amount of time that doctors have, although I would say that VA doctors have a much lower panel of patients that they're expected to see on a daily basis than non-VA physicians. But I think by having this automated in a system or in a piece of material that can be pre-printed and just handed to the patient, and then it's up to the patient at that point to do any further research or read whatever is in there. We don't expect the doctor to spend 30 minutes or more talking about a list of medications and its side effects. We're expecting them to provide the information that's already created by the VA or whomever, and then the onus is on the patient and his family to do the research if they want to.
And I think, that just leads into the current system in terms of the informed consent form. I don't think, and I'm looking for confirmation from you, that the current system is not really generating that sort of more robust conversation between doctor and patient, so that they can go home. They want to talk to a pharmacist, they can do that. They can discuss it with their family members. They can do the research that they need to do. And I'm just concerned, and I'm looking for confirmation from you that you feel the same, is that, yes, they're going through and checking off and getting the patient to sign to say, you know, I've given you this information. You might not have read it, but I've given you the information. That's not getting to where we want to get to in terms of having a more robust conversation.
I would definitely agree. There are very few medications right now that require a signed form within the VA. They do require it for certain things, but generally medications are not included. And I just had surgery last week at the VA, and when they gave me prescriptions to send me home, nobody told me anything about it, and one of them is an opioid. So that's the type of thing that we're trying to prevent.
Thank you. My time's out, so I'll yield back.
Dr. Rowe?
Yeah, I would like to comment. Look, handing somebody a piece of paper is not health care and saying to read it. You have to have a doctor and a patient or a nurse practitioner or a nurse sit down and discuss the medication, what its risks and benefits and side effects. I did that for 30 years. And signing a piece of paper that just checking a box is not going to accomplish what we want to accomplish. I think what Ms. Brownlee wants to accomplish, we all on this committee want to accomplish. We have an opioid epidemic in the United States. We have, in the state of Tennessee, more people dying of overdose of prescription drugs than car wrecks. So and it's not just Tennessee, it's a huge problem. And so I think one way to do it, and obviously it's training the medical personnel better, training patients better, but I don't want to put another barrier. We're complaining now about not enough access for care for our veterans, and I think we're adding another layer of bureaucracy here that may not get the benefit that you desire and I desire, and that's the adequate prescription, the adequate use of a prescription that's written. I think that's what you really want at the end of the day. So those are my comments, and certainly if we can work on this, I would like to, but I say in its current form, I can't support it like it is. The other thing I didn't, not with this panel, but that Ms. Walorski brought up, that I didn't bring up a minute ago, was on the scheduling issue. I think it's fine to do these things, but once again, there's no teeth, there's no penalty if you don't do it. That's what I was listening to her legislation. In other words, I've been sitting here now for 7.5 years, and we find the VA doesn't comply or do something. There are no teeth. There's no teeth in it. There's no penalty if you don't comply. Okay, so they didn't comply. I think we got to look and have some teeth in this bill that she has, and I would like to work with her on that. She's not here right now, but I think we need to do that. I've seen that over and over and over again here. I yield back.
Thank you, Dr. Rowe. Mr. Takano, you have any questions?
Thank you, Mr. Chairman. My question relates to HR 3956. The VA Health Center Management Stability Improvement Act. And you are in medical centers every day. How important is it to have a full-time medical center director in the facility and making day-to-day decisions and strategic decisions about care for veterans?
Mr. Takano? DAV has not received a resolution to the hiring of VA Medical Center directors. However, we recognize the importance of VA having a fully staffed personnel to take care of veterans. So we see that leadership would be part of that process.
Can you comment on how having the leadership, having a permanent full-time director instead of acting directors, what effect that has on the morale of VA employees who go to work every day in a particular facility?
Not from an organization standpoint, but from a veteran standpoint, being an employee and having my leader present to direct the operations of the establishment would always be a plus.
And relate to HR 2460, adult daycare in state veterans' homes. What concerns do you have for the VA to contract some of its services to the state veteran home?
Well, unfortunately, back in 2006, when Congress passed the bill to provide no-cost skilled nursing care, it took the VA to implement that. It took about 3 years to implement the reimbursement process. It was very painful to a lot of veterans who truly deserved the care, and they did work with us to go retroactive, to get the care paid for. What I'm concerned about now is the fact that a lot of members of this committee understand that the VA is going to establish new regulations for adult day health care and for domiciliary care. Back in 2008, 8 years ago, I was part of a team that worked on Vermont Avenue with the VA to try and update the adult day health care regulations, which hadn't been done for years. And it's now 8 years later, and we're still waiting for that regulation. My nursing home on Long Island in Stony Brook serves as a model for adult day health care. I think it's a wonderful program. And we've had visits from about 16 different states over the past 3 years. And I can tell you assuredly that there are many state veterans homes that want to get into the game. Two things have to happen. We need the new regulations published. We've been told for 8 years that any minute now they're coming out. And secondly, this bill for our 70% population will help with the proper funding to keep those veterans out of the nursing home side and back into their communities while accessing the services they truly deserve.
Thank you. Thank you for your response. On HR 3989, the Support Our Military Veterans Caregivers Act, have you heard any concerns with the caregiver program as currently managed by the VA?
Some of the, Representative Cano, some of the concerns that we have is that there is not clear guidance with the current directive that VA has. Some of the issues would be medical determination versus a clinical determination. These things are not clear for veterans to understand and decipher through. Another issue that we have would be, should a vision director decide to request an external review, the key word there is should, so that process should be automatic if the veteran is requesting a review.
Well, is it necessary to set up an independent appeals process?
Can you rephrase that question?
Well, is it necessary to set up an independent appeals process that's conceived in this bill?
Absolutely. It is necessary to set up some process in which the veteran has an opportunity to have a decision reviewed. And it should be a clear process to where all steps in the process are known to the veteran throughout the entire process.
But what I'm trying to get is, are there changes that could be implemented instead to improve the existing appeals process we have at VA, instead of setting up an entirely new separate independent process?
Well, the process needs to be made clear. It's not clear at all. It's not clear in the steps that the veteran is to take. It's not clear as far as the language that's used in the terminology of the directive that is currently before us.
Okay. Mr. Chairman, I think, you know, this has been a long problem for us, and it's a subject of much further examination. But anyway, I yield back.
I agree with you, Mr. DeCano. Dr. Wenstrup.
Thank you, Mr. Chairman. Thank you all for being here today. You know, I think on Mr. Zeldin's bill, you know, as a practicing physician, the more you can do on an outpatient basis, keep people in their home, in their own home, is typically better, or at least as an option for them. And it's otherwise helpful for the patient overall towards their quality of life. For some, it may be better to not be in their own home. And so to me, that seems like a very viable option as long as the care that's necessary is rendered. As far as the opioids, you know, I always felt an obligation, and still do when I prescribe, to make sure that I'm informing patients of side effects. I make sure that I'm not doing something that's contraindicated with their other medications. I make sure that they don't have any allergies to medications I'm prescribing. These are the things that doctors normally do. Now, we know there's a problem, not only in the VA, but outside the VA, where people were over-prescribing. And so, to me, a lot of that onus falls on the physician and patient relationship, but there was also always the double check, if you will, from the pharmacy. And you get a prescription today, and you do get handed that information, and you got stickers all over your prescription that are giving you the warning. So I think we really need to look at what really needs to be done to be effective to make sure that patients are aware of the risks, and in this case of dependency and addiction, and maybe make sure that we're doing that. But I agree with Dr. Rowe, some of it can be too time-consuming, and the doctors here would probably agree that sometimes one of the worst things a patient could have is access to too much information, because they find out that 1 in 10 million has some side effect that suddenly they're paranoid about, and they don't want to take the antibiotic that's supposed to help them and will help them. So we have to be a little careful about how we do that, but I think there is an obligation, obviously, to make sure that you're doing the right thing, informing patients properly. So we'd like to work with you on that. I yield back. Thanks.
Dr. Abraham?
Thank you, Mr. Chairman. A couple of comments on Mr. Zeldin's bill 2460 and Mr. Pisgano. They have certainly a civilian side of that also, and being a family practice doc, it does work. So I am much in support of that. The thing that nursing homes do, I think, as good a job as they can with the patient load that they have. But if that patient is in an adult daycare 6 hours a day, you're providing OT, PT, you're moving the patient, you're grooming the patient, that patient is being mobile as much as possible, and I understand the significant impairment that some of those patients unfortunately have, but that increases joint mobility, it increases tissue oxygenation, just a better outcome for the patient. And if you look at objective data, which certainly I think most of us on the panel here have done, certainly the ones that are physicians, facilities such as yours at Stony Brook, compared to 24-hour around-the-clock in a nursing home, less infection rate, less resistance to antibiotics such as the MRSA epidemic that we're having now. So, I think it's a great thing, and hopefully we can get this done. In response to Ms. Brownlee's bill, again, I, like Dr. Winstrup, we certainly hopefully provide the patient with information that he or she can make an informed decision, but it's like Dr. Rowe said, the epidemic is not only in Tennessee, Dr. Rowe, it is, there are more patients dying from opioid dependence all over the nation than car accidents. So it's a huge problem. We've got to figure this out. So I think it's great. I mean, we can tweak this, and we can certainly work with Ms. Brownlee and make this, we're, I think, smart enough to figure this out. But just the mere fact that we're having the discussion, I think is important, and we keep moving this legislation forward in some form or fashion. And like my colleagues here, Dr. Rowe and Dr. Winstrup, we want to make this work, and we're happy to work with you to find the right solution. And I yield back, Mr. Chairman.
Thank you, Dr. Abraham. Well, I want to thank the members of the panel for being here today, and I encourage you to continue to keep us informed as to changes that occur with you. And, we want to get your input on all the pieces of legislation that have been put forth today. So thank you very much for being here. You're now excused. So at this point, I welcome the third and final panel of the witness table. Joining us from the Department of Veteran Affairs is Dr. Maureen McCarthy, the Assistant Deputy Undersecretary for Health for Patient Care Services. And she's accompanied by Susan Blout, the Chief Counsel for the Health Care Law Group of the Office of General Counsel. So, Dr. McCarthy, you may begin your testimony when you're ready.
Thank you, sir. Good morning, rather. Chairman Benishek, Ranking Member Brownlee, and members of the committee. Thank you for the opportunity to be here today to present our views on several bills that would affect VA healthcare programs and services. Joining me today is Susan Blauert, Chief Counsel for General Counsel's Healthcare Law Group. First, I want to convey my gratitude and appreciation for the commitment of the members of the committee who seek to improve and provide these authorities to the VA. Though the department writing oppose the majority of the bills, we do so for purposes of resources, operations, and in some cases duplication of existing programs. We look forward to continued collaboration with the committee and its members to ensure we are providing the services and care our veterans deserve. Regarding H.R. 4977, VA policies already require directors to certify compliance with the scheduling directors and explain gaps in compliance based on data collected at the facility. We also know veterans aren't required to schedule hospital care. They can walk into the emergency department or be admitted directly by primary care. VA needs the flexibility to set scheduling standards that are clinically appropriate and that can adapt to changes in the way veterans access health care. And I'll be happy to explain some of the structures we have in place at this point to monitor that. Regarding H.R. 2460, VA supports growing adult day health care programs because we definitely want to rebalance how we use home and community-based services versus institutional services. Veterans and their families are supportive of initiatives that permit them to age in place and avoid nursing home care. However, H.R. 2460 would base payment rates for these programs on nursing home care rates, which are much higher given the needed level of care. Whereas nursing home residents live at the facility and receive 24-hour nursing home care, these adult day health care participants live at home and may use the program for, say, 6 to 8 hours. Thus, this bill would require VA to pay 2/3 of the rate that VA pays for a higher level of care for furnishing a lower level of care for about 1/3 of the time. Additionally, VA believes that shifting payments from a grant to a contract mechanism would place additional requirements on state homes that have been proven burdensome and difficult to implement. With regard to H.R. 3989, VA believes that the current process regarding review of eligibility determinations for the comprehensive program of support to caregivers effectively furthers VHA's policy to provide access to fair and impartial review of disputes. Currently, when an individual appeals the treatment decision of the care team about eligibility for participation, decisions are made by VHA leadership who have direct oversight of the clinical team that has been more intimately involved in the veteran's care. In contrast, the proposed external clinical review would be provided through an independent contractor who in turn would employ a panel of healthcare professionals not necessarily familiar with the case. We also emphasize that our caregiver program was designed by Congress to be a clinical treatment program and not a benefit program. Next, VA agrees that employment of physician assistants, a top 5 mission-critical position within VA, should be prioritized. Thus, VA supports the pilot program in Section 2 of H.R. 3974. The pilot program is a win-win for VA and the scholarship recipients, as VA will reduce future recruitment costs while scholarship recipients fulfill their service agreements. That being said, VA recommends removing certain prerequisites described in the bill, and also a relook at the timeline of the expected numbers of participants. VA also supports Section 4, including the PA occupation being included in the locality pay system in VA. We feel that would be an important element in addressing recruitment and retention difficulties associated with the pay disparity between private sector market pay and VA pay schedules. While VA supports Sections 2 and 4, VA believes that Section 3 would not be the best tool to address the current PA shortage, as some facilities do not report issues recruiting PAs, requiring all facilities to advertise education debt reduction program for PA positions would deny some facilities the ability and flexibility to make these awards for other critical positions for them. Next, VA is appreciative of your efforts to address challenges with recruiting and filling VA Medical Center Director positions with H.R. 3956. VA has taken several steps to reduce the number of vacant positions. For example, VA anticipates having nominees identified for about 20 of the 34 vacancies by the end of April. In addition, VA submitted a legislative proposal requesting the ability to transition all medical center directors from Title V to Title 38, which will provide additional compensation and staffing flexibilities, thereby relieving some of the current challenges with attracting highly qualified candidates to serve in these leadership roles. VA seeks your support of that proposal to ensure the resolution of the medical center director staffing challenges. With regard to the draft bill to establish a list of drugs requiring an increased level of informed consent, VA believes that we've met these terms in what we have going at this point. I'm happy to share a list of medications for which VA already requires informed consent. VA feels the draft bill would burden veterans and their care providers by introducing some unnecessary steps and delays in what is standard informed consent process for high-risk medications. We list several other concerns in the written statement. That being said, we were at the time unaware of the problem the legislation was supposed to remedy, but acknowledge indeed Ranking Member Brownlee's statement about the opioids and the purpose of this to address that. So we request an opportunity to meet with the committee to ascertain the members' concerns and work together. Thank you, Mr. Chairman and Ranking Member, for the opportunity to testify before you today. My colleague and I would be pleased to respond to questions that you or other members may have at this time. Thank you.
Well, thank you, Dr. McCarthy, for your testimony. I'll yield myself 5 minutes for some questions. So you think this medical center thing, this director program, is primarily the fact that they don't pay them enough? Is that what we're getting at? You're changing the section to Section 38? I don't remember the numbers.
I think the pay is part of the problem. A typical VA medical center director compared to someone running a similar hospital in the private sector makes a fraction of what the private sector person makes. Some of the challenges are where our medical centers are located and people's ability to move to those locations, but salaries are a big piece of it. You may have noticed we've had some negative media attention over the last few years, and in particular, the sense of people who may in the past have considered becoming a director are feeling a lack of personal safety in assuming the role with the increased number of requirements placed on them. So I think it's multifactorial, but I do think salary would help. I also think a greater sense of appreciation for what they're doing and the challenges they face would help. And I have personally reached out to numbers of individuals that might be in acting roles and talked with them about why they are not stepping up to apply. And a number of them are talking about really the challenges and the pressures that are on our medical center directors right now with the intense level of oversight. That said, that's not to say that we shouldn't have oversight, but it's very, very challenging for all of them right now.
Well, thank you for that. You know, I don't know if you're familiar, but I worked at a VA for 20 years as a physician, and one of the challenges we had there was that the VA directors turned over every 2 years in many cases. And even with that 2-year tenure, things didn't get done. And with a 120-day tenure, you realize that these folks are not making the critical decisions that need to be made because they're worried about the consequences of any decision they make as a temporary person. So, I'm willing to, work to make this happen. And any changes in the law that have to be made to, are there changes in the law that need to be done to get the medical director, get this changed to this other section? Do we need to change the law to do that?
So there was a legislative proposal VA submitted on changing those positions from Title V to Title 38, which would give more salary flexibility.
All right, okay. I might want to go on to this, the stayed home issue. You heard the testimony that these veterans that we're talking about, they're eligible for nursing home care now. So an effort to, cut the cost of that and to still provide them with the care they need seems like a no-brainer to me. Why do you object to that?
Sir, we definitely support veterans and their families as they make these decisions to age in place and want to do what we can to help them. We have a number of services in place already to support that. Our concern is
we're not talking about people that aren't eligible for nursing home care and that need, these are people that are eligible for nursing home care, and if, either they go to a nursing home or they get this. I mean, so I guess you're saving money, aren't you? Or you want to provide this care a different way? I'm not sure that that's actually happening, though.
So as we move, shifting that balance I was talking about between institutionalization and the care and community-based services that help people stay in their home, we definitely are trying to shift that balance for sure. Our concern was with the actual dollar number, and was it indeed a fair calculation to pay 2/3 of the cost of a nursing home for them to be there for 6 to 8 hours? We have.
But I think, to tell you the truth, if you had to pay somebody to go to the home for 6 to 8 hours, it would cost you more than $300. And Dr. McCarthy, you understand what I'm talking about? They got a nurse to go to the home for 6 to 8 hours and to do what they're going to do. And you can't get one nurse to do that. They can't cut the hair, and more than one person needs to be doing it if they're in the patient's home. So, I mean, I have a little bit of trouble trying to figure out that argument.
So just so you know, we've been working with the state veterans homes and have talked with them about two kinds of adult day health care models. One, which is a medical model. I think the classic example would be a post-stroke patient, for instance, that needs a lot of direct nursing care and a comprehensive health care team. And the other is the social model.
I understand where you're going. I'm just telling you, this is not like respite care where you're just babysitting the patient, and then, the alternative is full care. You're talking about apples and oranges here. So, to me, if you don't want to deny the patient. I mean, it's cheaper to deny the patient the care. That's
not in the
for
long
sure.
run, I don't think. But
I know, but I don't think you're talking about that.
Yeah.
But it kind of gives me the idea that might be happening.
So if I could I just...
I mean? It's definitely cheaper to deny the care.
Right.
So I just want to...
I agree with you. I was about to say that there are two models, and one is a more medical model, and one is a more social model. And so the way it's written is that this would apply to both models. And what we feel is that if it were a more social model, then the compensation wouldn't be justified. So we do have a regulation that was out for comment, and we are addressing the comments at this point. But it's really to look at two different models.
I think we're talking about two different patient sets, though. And we're talking about a patient set that the patient is 70% disabled and eligible for nursing home placement, as I understand it. So that's different than what you're talking about.
Actually, that's 70.
Well, I'm out of time, though. I appreciate it, but I'd like to have you follow up so I understand this better.
I'd be happy to do that.
Mr. Takano, do you have any questions?
Yes, Mr. Chairman. Regarding the draft scheduling compliance, this committee heard just yesterday about the continued challenges veterans face in scheduling access to care. And part of the inconsistency stems from the fact that schedulers are working under an interim scheduling directive. Once a comprehensive scheduling directive is finalized, it would seem to me that ensuring greater compliance will help improve wait times and get veterans the care they need. Does the VMAC director currently have to comply with VA regulations and law?
Yes. We believe so, yes. There's an expectation, if we could talk about scheduling in particular, that the medical center director and the network director would visit the frontline staff that are involved in scheduling periodically. And in addition, there's been a tool developed to look at scheduling and the process to look for any kind of irregularities. It looks at a total of 5 measures of compliance and practice to help figure out if anybody is manipulating data in any particular way. And if that's apparent, it'll be apparent to the medical center, it'll be apparent to the visitor, it'll be apparent to leadership in VA central office. So there is a tool that people are using to help and verify in addition to the expectations of the visits and the certifications.
And how does the central office verify the compliance?
What's used is a database, and I've had this explained to me. What they use is a measure of 5 things. They look at the average new patient wait time, the canceled by patient rate, the established patient 0-day wait, and then in terms of practice, what's going on with the electronic wait list and the established patient measures. And based on outlier status on any of those, it's a warning sign that things may not be accurately followed in terms of the scheduling directive and the scheduling processes in place. That's the warning sign, and then there's a review that happens that's triggered by those kinds of events. But in addition, people are following all the time the wait lists and in particular the need for urgent care and so forth.
Well, do you think that that effective compliance, verification of compliance through the central office, would this lead to enhanced veterans' access to care?
So compliance and access are likely related, yes, but I think in my mind some of that is separate. I think we're all about improving access, and compliance is more asking, are we doing it right and are we doing the right thing? But obviously, if we're compliant, we would get access. I just think about those in 2 parallel spheres. I'm sorry.
Okay, I want to move on to the HR 3989, Support Our Military Caregivers Act. Can you briefly explain the current process to determine if a family is eligible for caregiver assistance? And what recourse does a family have if they disagree with the decision?
So the way Congress wrote this for VA is different how it's written for DOD. For DOD, it's a benefit. For VA, it's part of the treatment plan. So the treatment team makes a recommendation for a veteran to have a caregiver based on the current needs of the veteran at the time the assessment is made. There includes a series of events, including home visits and so forth. Typically, it's a 90-day process of evaluation. And so all of the kinds of things that are determined are if the veteran needs this care, what kind of level is needed, and then an assessment of how best to accomplish this and the support that the family member would need. There's training that goes in to what the family member gets. And so that there's a tier assigned for the level which corresponds to the compensation level that the family member receives.
If I could interrupt or add on to that, if a service member's health situation changes, will the family have to begin the process all over again of evaluating the caregiver assistance?
Yes, because it's considered a treatment and not a benefit, and I think that's where there's a lot of misunderstanding. So when someone is assigned a benefit, it's an ongoing payment, whereas as part of the treatment plan, the veteran may or may not need the ongoing support of a caregiver. And initially, say, after transitioning from a polytrauma facility, they may need a lot more support, but as time goes on, they may not need the assistance at the same level, the same tier, or they may even not need the assistance of the caregiver, which is the clinical decision.
All right. Thank you very much. Thank you, Mr. Chairman.
Dr. Rowe?
Just a couple of brief questions. Yesterday, the VA has 32,000 schedulers for their VA system, and that's half the population of the city I live in, which is the largest city in the 1st Congressional District of Tennessee. So there are only about 3 or 4 towns in the whole district that are bigger than the number of schedulers the VA has. And, yesterday we were sitting in this same room, and we heard 2 very different stories about scheduling. And I think that it is important for us to get that straight. And I would support her bill. And the reason is because we can't get information that we can understand up here about wait times. We hear the secretary say it's 4 days, you go home, and you hear everybody you talk about, nobody's getting in 4 days. So I think that's the problem we have here is it's a definition. And I know yesterday when I went over it, it's like when a veteran calls in and they say, well, we don't have an appointment for 6 weeks. Well, that'd be okay. When they'd really like to be seen in about 2 weeks. And then that's considered the day that they actually agreed to, so there's no wait time. even though in reality there is a month's wait time or maybe longer than that. So I think we do need to look at that and be, and first of all, I told the Secretary the Undersecretary of Health, Dr. Shulkin, yesterday, we need just to define what that is, and whatever it is, it is. So we're all, singing off the same song page. The second thing, Dr. Benishek was drilling down on this, and I just did some numbers. I can't understand your VA estimated cost on Mr. Zeldin's bill. And you look here and you say that the estimated cost is $1.7 million in the first year. I just did some simple arithmetic. If somebody goes 5 days a week to the adult daycare center that we just heard about at $318, $76,000 a year, that means for $1.7 million, you take care of 25 people. So how did you come up with that number? And then it says $2.1 million in the second year. It makes no sense to me. If you multiply 318 times 5, then multiply it times how many weeks, 52 weeks a year, or how many you go, and if you, at $450, it's, at his institution, it's $164,000, and to Dr. Benishek's point, that's a lot cheaper, almost $100,000 a year, less expensive. And I agree with you that you should look at medical and social because all patients are not the same. That's totally correct on that.
Right. So, sir, I'll be happy to kind of do a breakdown of the costs, but I believe part of the issue is that many of the people that go to the adult day health care centers go 3 days a week and not 5.
Well, it's still, okay, then it's $50,000 a year.
Okay.
I can do that math in my head pretty quick.
Okay. All right. If you wouldn't mind, I'd like to get back with you with a description of the numbers.
You see where I'm concerned, though. 1.7 million is 50,000, 30 people is $1.5 million a year. So I don't know how in the world the VA came up with that small of a number.
All right. I will rework that, and I promise we'll get back to you.
Okay, thanks. I yield back.
Dr. Abraham.
Thank you, Mr. Chairman. Just a couple of things on Dr. Benishek's and Dr. Rose, just comments on the adult day care living. I think I could arguably make the argument that with adult daycare the way it is now and the way it's perceived in Mr. Zeldin's bill, that you're getting both the social and the medical input there. So yeah, I think you're getting more bang for your buck than certainly, in the nursing home situation. I mean, I've known both. I've treated patients in both, and they both do a great job. But I think when you're talking just strictly dollars with the adult daycare, I mean, you're certainly getting a little more bang for your buck. And the patient, more importantly, is getting maybe some improved therapy on joint mobility and that type of deal. The other issue on the, you said you've got a list of drugs there that require, and I'll just ask you if you'll give me a copy to my office, I'd appreciate it. But I'm assuming that one of those already are the opioids. Is that a correct statement?
The long-term opioid. Right,
okay. And, like Dr. Rose said, and the docs up here know, it is burdensome, but Mrs. Zametta had some good alternatives as how we get that patient to, I guess, become more informed. So again, I think it's a good conversation, but I guess, again, let's go back to the objective data. We've already got informed consent for the long-term opioids, but we still have an increasing opioid epidemic. So the question bodes, well, is the informed consent model working as it is? Evidently not. And again, my previous statement, I think we're smart enough to work with Ms. Brownlee and to figure this out and get it right with Ms. Zumato and the VSOs to get their input where we can hopefully get the right combination of what it does take to start chipping away at this opioid addiction stuff. The question I have for you made the comment in your statement that in the bill of the PAs that the VA was somewhat opposed to some of the prerequisites required. Can you list those prerequisites that, I mean, I heard Ms. Custer, I was listening very acutely to what the prerequisites are. Which ones are the VA opposed to knocking out of the box?
So it's just a few. There's a requirement for hiring executive director of one program and another position, and it requires that the person be currently employed by VA at the time of the passage of the legislation and that the person be a veteran. And that limits who would be eligible to apply
What
for
would-
those positions.
Would the VA be okay with or be in favor of giving the veteran the priority of that slot, of the PA slot? I mean, we all know we need more healthcare providers in the system, and if we've got a combat veteran, either he or she, that has been on the front line serving as a medic or in some healthcare job already, they are far ahead of the game as far as somebody coming off the street, literally, and just starting the program anew. So they bring so much knowledge base already, and that's what it requires in a PA and an NP position, to have that knowledge base, and they've already got that. So the question is, VA okay with the VA getting the preference or the
veteran preference
yes.
would that, just changing that would help. That
Okay.
exactly.
All right, thank you, Mr. Chairman. I'll yield back.
Thank you, Dr. Abraham. Does anyone have any further questions?
Yes. Could you submit a list of the medications or drugs for the record?
I'd be happy to do that, and I brought some copies
Okay,
with me.
thank you. That's what I wanted. That's it. Yeah.
And just so you know, this was derived from our list of informed consents, so it lists particular drugs, and you'll see a lot of chemotherapy drugs and so forth. But in addition, it talks about like the spinal injections and so forth for anesthesia, but it certainly has all the other drugs. And under anesthesia and pain management, about the 10th one down is consent for long-term opioid therapy for pain. Okay.
All right, thank you, Dr. McCarthy.
Okay.
Thank you.
Thank you.
I yield back.
The third panel is now excused, so
Thank
you
you very
for being
much.
here. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. I'd like to once again thank all our witnesses and audience members today for joining us this morning. The hearing is now adjourned.